Button. Let's record. Okay, let's see. Ed, would you like to introduce yourself?
Yeah, you bet. Hey, good morning, everybody. Ed Kaiser here. I am a family trained nurse practitioner in Omaha, Nebraska. I've been working with substance use disorder for the last almost 8 years. So excited to be with you guys again. Thanks for being on with us.
Thanks, Ed. Let's see. Mary, you're next on my screen.
Hi, I'm Mary. I am a psychiatric nurse practitioner and an attorney in the state of Nebraska.
Thanks, Mary. And John.
Hi guys, John Massey, and I'm a pain doc in Lincoln.
Thanks, John. Todd.
Good morning, Todd Stoll. I'm a psychiatrist.
Thank you. And Stephanie.
Good morning, all. Sorry, I'm still driving to my office, so I think my camera's off. But good morning, everyone. I'm a psychiatrist out in Western Nebraska, Rapid City area. It's nice to see you all this morning.
Thanks, Stephanie. Okay, Alex, I will let you introduce yourselves and take it away.
Morning, everybody. I'm Alex Dworak. I am a family physician who practices underserved medicine in Omaha at a federally qualified health center. I am glad to have you all here. This is an update of a presentation I did previously. Will, can you give me a thumbs up? My screen share worked there.
Looks
Awesome.
good.
Okay. Again, I do have a couple of things here that I looked for newer literature. I will add to the disclosures here. I'm not any funnier than I was the last time I did this, so apologies in advance. I have kind of two parts of it. One focused on OUD specifically, the other on some pregnancy-related updates to infectious diseases, which is a passion of mine and which often will so often go together with substance use. I'm trying to think of the word. Syndemic approach is recommended, where we look at these things as, literally running together if you go to the Greek. So I will have some stuff on that at the end. I'll try to move enough that I have time for questions. Again, I'm very glad to bring some of these updates to this group. So. All right, so the big question, there is still a lot of stigma, a lot of concern, a lot of worry on patients and provider. Isn't this going to hurt the baby? So should we offer medication-assisted treatment to people with opioid use disorders? Um, all right, that's our presentation. Will, I'll back to you if we have any cases. Thank you so much, everybody. All right. Yes, but let's talk more about the details. So I wanted to go back through organogenesis briefly, there's a shout out to Dr. Turpin at Nebraska Medicine for those of us who train there, coming up in the following slides. And then think about both opioid treatment and pain treatment during pregnancy. And again, these things very often go together, as we know. And then thinking about injection drug use and some infectious complications that can go along with that, both for pre-pregnancy planning. Again, something I go talk about with my residents is work very hard not to start a medicine in someone who's not pregnant that will immediately become a disaster if they do get pregnant, whether they're planning to or not. And then we'll hopefully again have some time for cases at the end if people have questions. So again, organogenesis is happening from weeks 3 to 8, we've got endoderm, ectoderm, and mesoderm. Once this process is complete, a lot of the concerns for congenital malformations are past. But again, most of the time that happens, well, not most of the time, but it can often happen before somebody realizes they're pregnant. Uh, but again, at the end of week 8, organ systems have typically developed. And again, this is counting from last menstrual period. So this is when the person's been pregnant for about 6 weeks, according to this count. And then the fetal period is beginning. But again, people may, unless they're paying close attention and happen to have regular cycles, they may not have realized they're pregnant during this time. So even more reason to think ahead. And if somebody has a functioning uterus, again, don't do anything that would be immediately become a bad idea. But in this situation, especially, we need to weigh, well, we have our treatment intervention, but what's the cost of not treating or withholding treatment and what is likely to happen? The phrase that was drilled into me during my training is, healthy mom, healthy baby, healthy parent, healthy baby. We need to look out for what's going to be in the best interest of both people. But if the person who's pregnant is having an uncontrolled substance use disorder, that is bad for them and bad for the baby. And the risk benefit ratio should always be looked at in that light. Um, so if people are on opioids, do they cross the placenta? Yes, and we have opioid receptors in our brains, and that can impact fetuses and babies. And it's ideal to avoid this if at all possible. So we want to try to avoid chronic opioid therapy during pregnancy to the best of our ability. Uh, that said, again, an opioid use disorder is not the same as chronic pain where things are going well. There's always a chance that chronic pain treatment with opioids will turn into an opioid use disorder. What I tell my trainees is if you get enough people penicillin, some of them are going to get a rash, and occasionally someone will get anaphylaxis. If you treat enough people for pain and you use opioids, some of them are going to misuse them, and some of them are going to develop an opioid use disorder. And just like the anaphylaxis wasn't their fault or like a moral issue, I don't think we should look at this any differently. It's a thing that we know happens more than never, and we need to have a plan for it. But again, if at all possible, opioids should be avoided during pregnancy. There is some concern that they can have adverse long-term cognitive outcomes, and just I mean, the general principle is the fewer interventions you do in pregnancy, the better. Zero meds is always preferable to one med if the patient can do well with zero meds or with one med instead of two meds. That's just general principle. And again, where does this potential concern come from? Uh, it's complicated, but in this study, again, multifactorial. This is kind of the statistics equivalent of radiology saying, please correlate clinically. I mean, what's going on genetically? Are people using other substances, including smoking or alcohol? Are they having good nutrition? If people are in poverty and, even without changes to Medicaid and SNAP and other benefits or living in food deserts and stuff, that will all have an impact too. How much stress are people under? Is their skin color, their immigration status, their financial status, having a loved one in the criminal justice system, job security, all those things. They have another loved one in the home, especially who has a chronic substance use problem. Are they a military veteran? Have they been exposed to trauma? All these things that which play off each other can be adverse childhood experiences, which is something else that my psychiatry colleagues would be better positioned to discuss. But that all plays in. What's somebody's education level, which often tracks pretty closely with how wealthy are they, and how much of a social support network do they have. And so again, and then we know opioid use will also kind of track with those things too. I mean, none of these things is an isolated variable; they're all interdependent variables. And so if we're thinking about opioid impacts, yes, and all these other things all together. And I definitely wouldn't look at somebody who has used some opioids and be like, well, that's why your kid is, going to be messed up or something like that. That kind of judgmental approach really never is. I struggle to think of a time when that would be helpful to somebody's overall well-being and recovery. So, in general, if you're thinking about that, which I definitely had some of that exposure in my training of looking at people in a judgmental fashion. I've tried to deprogram my brain and stop doing that, and I think we would all do well because if we were the patient, are we going to respond better if we're being judged or if we're being supported? So, okay, so we also think about withdrawal. So if there's opioids antenatally, then what's going to happen when there's no opioids postnatally? There were more concerns with methadone from this series in the 70s. I was born in 1979. It's been a minute since then. But people who were on methadone had less in utero withdrawal, and that showed benefit. This is something that has literally been known longer than I've been alive. To not to yes, as my first slide said, offer this treatment. Don't deny treatment because somebody's pregnant. That would be a bad thing. So, and I think we all know that. I'm preaching to the choir here. The people who might have that, oh no, you can't do that, are probably not as likely to attend a series like this because of the biases that we kind of soak up unintentionally, whether we're trying to or not. But again, this is not just like my opinion, man. Big Lebowski reference for those of us of a certain age. This is ACOG. So I went back and this was reaffirmed in 2021. As of 2 days ago, when I was finalizing things, they have not updated this. ACOG's official position is yes, offer this treatment. Another thing I was told in my residency and when I was doing deliveries, if you're going to do something different than what the ACOG guidelines say, you better have a real good reason for it. And in this case, I don't think anybody has a good enough reason. And you also have the backing of the premier professional society for physicians, at least. I can't imagine the midwife literature would say any differently. But again, this is the standard, and they say yes, do this. So uh, don't feel like you're out on a limb doing this. Quite the contrary. I think we would be in greater liability if somebody looks like they need this or obviously needs this, and we say no. Okay. And then, yeah, combating the epidemic. All healthcare providers need to take an active role. Again, thank you all for being here. This is awesome. I wish more people thought like you and wanted to educate themselves to combat this. I know that I didn't get enough training in this. I had Purdue Pharma drug reps telling me how awesome OxyContin was when I was an intern. So I've had to teach myself and seek out opportunities like this and hanging out with people like my fellow echo faculty to get better. I got my X waiver from ASAM back when that was a thing. And I just found out about the Midwest Society of Addiction Medicine. Two of my med students were on a presentation this past weekend. So there's other ways where we can keep educating ourselves. But it all starts with us seeing these patients as people and wanting to help them. So again, good job, y'all. Keep this up. And again, pregnancy is general time when people are going to have a lot more touch points with the medical system. This is a chance to reach people. So there's discussion of like syringe programs. Apart from all their other benefits of reducing infectious diseases and reducing risk to law enforcement and first responders, it's more touch points with somebody who cares. A patient who in recovery who testified at a hearing about that said he'd lost a lot of friends, and if somebody who I can't remember his exact words were, if somebody who gave a shit about me would have interacted with me sooner, maybe I would have been in recovery sooner. But again, when people are coming in for pregnancy care, it's touch points with the medical system. It's a chance for us to show that we care and to again welcome people non-judgmentally and at a time when they're often very motivated to try to be healthy. And again, as for anybody pregnant or not, if they just try to white knuckle it, we know with opioids that's likely to fail. And we have a chance to help them. And we also have a chance to blow it and give them a bad interaction, and then they're going to get less care, have a more adversarial relationship. And this is something that I've seen personally and that we know is reported in literature for lots of minority groups, indigenous folks, combat veterans, queer patients, immigrants and refugees. Again, somebody has a bad interaction with reason to, where they're hurt or they have reason to be afraid. You have to do a lot of work to rebuild that trust, and probably a lot of care is going to get missed. And if they're going to show up later and in worse situations than they would have. So, and also, you can't look at people and be like, you have an opioid problem, but you don't. That's obviously not how that works. And something I also know extremely well from my HIV work, universal screening needs to be universal. An important part of this is not missing people, but it's also breaking down the stigma in people who may be at lower risk and just normalizing it. That is crucial. So, and this should be part of OB care. If you are, providing obstetric care yourself, this should be something that you're asking about and looking at your workflow to have it, checked. This is something we should do in primary care and specialty care. Once somebody's seeing an addiction specialist, usually things are a bit more defined than that, but it's still good to be mindful of all the different substances somebody might be using. And if you're referring people, it's good to, ask your referral obstetric partners, like your midwife group, your OB-GYNs, your partners who do obstetrics and C-sections. Hey, is this something that you all, that your workflow comprises? And if not, could we talk about how it could be normalized as part of that? Okay, I'm using the D word here. Oh well. We need to recognize and differentiate between medically prescribed opioids where things are going well, opioid misuse where somebody is more risky using, and untreated opioid use disorder where things are off the rails. These should be looked at differently and offer the appropriate level of support. And If somebody is having a delivery where opioids have been in the picture, you need your pediatric team to be aware of that. And there are protocols. NICU is not always needed, but it's a good idea to have a plan to get the baby to the NICU. And the more rural you are, and your standard plan for that should be on standby at least. And I would be talking to your neonatologist and documenting that conversation during and after the delivery, even if things are going well. So, okay. And then again, this is per ACOG, universal screening, brief intervention, and referral for treatment. So the SBIRT model improves maternal and infant outcomes. Boy, that like if there's one thing we should all be able to agree on, no matter our perspective, better maternal and infant outcomes is like that's as much of a slam dunk as I think we're ever going to get in medicine. And multidisciplinary approach without criminal sanctions. Mary has talked about criminal justice interactions, but again, I struggle to think how, for most people, criminal justice system interactions and uh, charges and records that follow them are going to improve their long-term prospects. Occasionally, some people have, I've had some people say that it was a good thing for them that they were in prison because it made them change. But I think in general, if we can help somebody change without those things, which then become their own social determinant of health, that changes their odds of employment and avoids the potential for trauma in prison with assaults and witnessing violence and all the psychological stuff that goes with that. If we can get there without that, sounds like a good deal to me. Okay, and again, per ACOG, expert having a conversation. Screening should be universal. You should not only be like, wow, this person really can't get to their appointment. So we should, because then that's like, well, hey, are you using drugs? As opposed to like, hey, maybe their car broke down and they're in poverty, and they don't have family nearby, who can, support them, who happen to be wealthy enough to have a spare car sitting around or something. If we do targeted screening, that's going to miss people, and it's going to stigmatize the people that you target. And it's also a chance for bias to come in. So that's not optimal. Okay, and then there's a variety of things that could be used here. I looked up the NIDA quick screen, but again, I would look at your workflow or talk to your pregnancy providers about what their workflow is. Just having something that's in there to make sure that this doesn't get missed is a good thing. Just like getting your labs, looking at your blood type, getting ROGAM when applicable, doing your Group B straps. Like this should just be part of the process. Both to normalize it and to make sure it's not down to the clinician remembering, because this is the kind of algorithmic thing that decision support or workflow with nursing support exists for. Again, if possible, avoiding opioids for people living in chronic pain is good, or using the minimum dose. Incorporating consultants for other therapies, including movement, which is a good thing for everybody. I have a whole nother rant I could go on about, somebody's pregnant, so they need to like just sit there like a princess and never move and can't exercise. Super no. Yeah, just using as many other options as possible, which is a good idea when somebody's not pregnant too, but the stakes are higher when there's two patients instead of one. Okay, and there's this NIDA, which also includes alcohol, tobacco, prescription drugs for non-medical reasons, and then non-prescription drugs. Again, it just has a little script. Again, it's an expert model. This is not going to be an hour-long conversation, but it is going to be a chance to, make a note of it and refer somebody on, and then keep checking back and ask how somebody's doing. So. Okay, and again, ACOG is this is black and white. This is not this is not a polite suggestion. Opioid agonist pharmacotherapy is the recommendation. Please feel comfortable that if you're seeing somebody, this is the standard of care. And if you try to withdraw somebody, that we know that has very high recurrence rates. Substance use disorders are relapsing, remitting conditions, and they don't magically go away. When if somebody gets out through withdrawal, which sucks and can be an adverse experience, then they're not done. In fact, if somebody goes back after a period of abstinence, that's a high risk time for an unintentional overdose, even before the age of fentanyl, because they've lost their tolerance. This is, something that we know well, that somebody who goes into residential rehab, gets off of substances, loses their tolerance, and then relapses when they go back to their same environment, their same people that they're hanging around, their same stresses, their same triggers. They use, they're not tolerant anymore. Bam, they're down, and maybe they're dead. That happens more than never. And again, all that plus a second human in the picture, or more if they're twins or something. So, but again, agonist treatment, you can feel good about this, and you can reassure your patients who may also have some qualms about this that this is the way to go, and this is per ACOG. All right, the most important thing to remember from this talk. So. Okay. And then again, having NICU or at least pediatric monitoring with the option for NICU referral and normalizing that for families, like we're going to do what your baby needs. This may be what they need, depending on how they're doing. Our goal is that everybody's doing great when you all go home. So just so that people are, psychologically prepared for that. And again, if somebody is having, if you're helping them get into recovery, they may be at higher risk of STIs and other, bloodborne diseases, depending on how they're using, which route they're taking. Are they in unsafe situations? Are they, being trafficked or abused? Are they engaging in risky behaviors when they're intoxicated? This is how human beings work when they're altered, and how other human beings treat human beings, so, far too often, and that's more than never. And so trying to be mindful of those things, and again, offer in a non-judgmental way with a focus on helping people be healthy. Okay, and then again, if we think opioids are needed or if we don't have a better option, again, think that through, document, discuss it maybe with a partner, a consultant, a clinical pharmacist, use whatever resources you have available to you. You could consult the Echo group here if you don't have easy access to those things. As Will said, we can make ourselves available. Document the PDMP, which is a good idea anyway, and have a discussion with the patient about minimizing risks, and making sure that this is the best option. And again, that it's also well documented that you thought carefully about this. So, but if people are stable on agonist treatments, and not on illicit drugs, and those two things tend to go together. If somebody needs an agonist and is on it, they're less likely to be using other things, like kratom or whatever else, or even other substances like meth, for some people. Again, they can breastfeed. In resource poor settings, breastfeeding is considered to be more beneficial than risky for people living with HIV on treatment. In a resource rich setting like the United States, at least hopefully, although not every patient in the United States is in a resource rich microenvironment for sure. But again, for most people in the US, formula feeding is going to be recommended just because the baby is not at such high risk of malnutrition that we need to accept a slight risk of breastfeeding with HIV. The risk is very little. In the United States, it's a question of very little risk versus no risk. If we're more worried the baby might have trouble with malnutrition, breastfeeding is acceptable in other areas of the world. That's an indictment of how most of the world, or the resource poor world, gets nutrition compared to us more than anything. So, and then if people relapse and they have other substances in their system, it's important that they not breastfeed to avoid whatever they're using getting to baby. So, and then offering psychosocial support with therapy, addiction specialist consult as needed, and residential in some cases, talking to your social workers during delivery and afterward, and just trying to mobilize resources for people at a time of high vulnerability. And then family planning. Again, people should be able in charge of their own reproductive health. But somebody who has an unplanned pregnancy who didn't really want it because we didn't offer options, that's not ideal. Again, making sure people have options presented to them, not in a coercive way, but so they can make their own choices. Okay. And then looking at buprenorphine versus methadone head to head, for most of us outside Omaha and Lincoln, buprenorphine's going to be the option because there's not a methadone clinic. And because of Nixon era regulations, you can't prescribe methadone for opioid use disorders, not because of the molecule, but because of the law and politics. So that's going to be, you can have anyone you want as long as it's this one, I think, for a lot of folks outside major metro areas. But even here in Omaha, is there a lot of head-to-head data? According to this article from the New England Journal of Medicine, I didn't find anything more current than this. The answer is yes. People tend to do, here's all the numbers, but buprenorphine overall tends to be favorable. There were fewer adverse neonatal outcomes, but again, the parents did well regardless, which would track with what we know about non-pregnant outcomes. The main issue is get people who need an agonist access to an agonist. These both seem to perform quite well. So, and then another thing which oh look, primary care doctor thinks primary care is good. Shocking. But I do think that if people are getting specialized addiction services like in a methadone clinic, that's really kind of siloed and that's kind of all they do. That they are by necessity not going to be thinking as much about, some of the other things like infectious disease screening and other services because that's outside their remit and their training and their practice model. Whereas people getting buprenorphine from a primary care provider, like our whole gig is take care of the whole patient. Again, that's not to say that there's not a place for specialist addiction care, but making sure that people have access to overall services is always important. And if you are seeing somebody in a specialist fashion, having a good primary in your area that you can partner with to help look at the other aspects and to keep an eye on the whole patient is always a good deal. Okay. And then again, if you're using buprenorphine, you had less neonatal abstinence, fewer preterm births. That's a big quality indicator for overall pregnancy care. Small gestational age, low birth weight. That's another one. There was not a correlation between opioid agonist treatment and C-sections or severe maternal complications. So. All right, and then again, you may be seeing people requesting a dose increase as pregnancy advances. As we know, pregnancy leads to an increase in the volume of distribution and metabolic changes. I would not tell somebody no just because they get to an arbitrary number. If they're having a lot of cravings or a concern for a relapse, or they have had a relapse, and they feel like a higher dose would be helpful to them, I would be inclined to listen to them, just in general. And 2 to 32 is kind of the range I would look at. Again, the goal is to help mom and baby be healthy. So, okay, well, and then trying to finish through things here so there are a chance for some questions. Again, this is a study from 2020, dose changes that were not shown to lead to worse outcomes. Higher doses or permitting higher doses when people are asking for them was associated with higher levels of retention and care. And again, anytime you're dealing with a specialized problem with a relapsing remitting condition, again, for me, the HIV treatment paradigm is front and center in my mind. Retention and care is a huge deal. You've identified the problem, but that doesn't matter if somebody falls out of care or isn't seen. That's a chronic high importance thing in HIV care. In addiction treatment, it's acutely important because it only takes one fentanyl overdose, and we've got another obituary. Okay, well, and then for neonatal abstinence syndrome, is that something to be concerned about? Yes. So again, I would be having a conversation with your pediatric or NICU team. Hey, this person's on opioid agonists. Have a consult pre-delivery. Have a plan. Again, this is a thing that we should be prepared for. Again, we can be monitoring. Buprenorphine and methadone both are longer half-life opioids, of course, than the shorter acting ones. So you might monitor the baby for a couple of days and make sure they're doing well. And just have a plan to reevaluate and normalize that for mom, family. Again, it's not a reason to avoid this treatment for somebody who needs it. Okay. Well, then I have this reference here. If people want to look at that, or review that with your local pregnancy or pediatric or NICU team, again, hopefully they're like, yeah, we know. But if they're haven't seen that, this is something that can be prepared for. So. And then again, a key point is don't Narcan the infant. That can cause a seizure. Again, the NICU and pediatric people should know that. But again, just don't be Narcanning them. Support them through it. And again, this document has more details here. I'm happy to, look through the literature and talk to some of my neonatology friends if people are trying to get this set up at your local facility and having trouble. So please let me know. Okay, and again, supportive care, which includes a lot of environmental things, skin to skin contact, and which is a good thing in general. Again, keep trying to avoid kind of yanking the baby away, but like keep mom and baby together as much as possible. So frequent feedings, recognizing that a baby's using a lot of energy during withdrawal. You can consider some IV fluids that may well be needed. But again, this is something that we should just lay the groundwork for so that families are not surprised. They're like, okay, yeah, this is something that we saw coming and we're going to manage it and baby's going to do great. And again, going back to encouraging breastfeeding, and this can actually lower the severity of neonatal abstinence syndrome. So, and less need for us to intervene. So that should be promoted as much as possible. All right. And then again, just having a plan with your neonatology team, morphine or methadone can be used. But again, just have your pediatric folks ready to help you with that. Okay, here's a withdrawal scale. Again, this is all part of this document I have linked here that I would use if I move to a rural setting and we're trying to plan with the pediatric team for this. So, and you just monitor, reassess. Again, it's pretty algorithmic. Okay. A question occasionally comes up, although not as much anymore, that, I'm pregnant. I should only take buprenorphine and not buprenorphine naloxone. But this has been looked at, and naloxone is not harmful in pregnancy. And so keeping the naloxone in for the diversion and misuse lowering benefits should be done, pregnant or not. So. All right, and then I thought hard about putting in a board game joke about autism here with acetaminophen, but held back. We should still use that. That is my personal recommendation. You can consider anti-inflammatories for short-term use, especially. Third trimester, you want to try to avoid that because of closure of the ductus arteriosus prematurely, which is not helpful. Episodic short-term use of opioids for a procedure or such appears to be safe. Regional anesthesia techniques, Dr. Massey is much more qualified to talk about the nuances of that than me, but those are safe as well for like a carpal tunnel procedure or something else, or for if somebody has a broken arm or something like that. Teratogenicity is highest in the first trimester. Again, the brain is still developing, and use in the second and third trimester after organ formation is done, like we talked about earlier, can still cause some neurologic issues. And again, we should try to minimize those as much as possible, of course. All right, well, yeah, then I was jumping ahead here, but yeah, try to avoid NSAIDs in the third trimester. Don't use ketamine. I don't think too many people are using that as much. I did not think to look up like esketamine or Spravato treatment during pregnancy. I would think that should be avoided, but that's something I could chase down if people are interested. Lidocaine for local anesthesia is safe, or like toenail removals and such. We want to try to avoid gabapentin due to the risk of more severe neonatal withdrawal syndrome if they're on an opioid. Again, if somebody has neuropathic pain pre-pregnancy, maybe a consult to an anesthesiologist would be a good idea to look for the safest option. Okay, and then there's some references for that. All right, so let me stop for a second. Will, are you seeing any questions in the chat? Because I could run through some of the syndemic things here, but now will be a good pausing point if people have other things they want to talk about before I jump into this, because this could take most of the rest of our time.
Yeah, no questions yet, but yeah, folks, if you have questions, you can drop those in the chat. You can also feel free to unmute and speak up, or there should be like a raise hand button on the bottom of your panel there. You can click that if you want to speak up, or you can just unmute now. Um, we got a comment from Kelly said Spravato is contraindicated in pregnancy.
Okay, yeah, that's what I would have figured, but thank you, Kelly, for confirming that.
Any other questions right now or comments, cases for Alex?
Yeah, I just figured before I put my HIV hat on and launch into this area of passion, I should give people a chance to pipe up if they would like.
Let's see, a question from Lindsay. Can you show the naloxone slide again as to
Oh,
why not to use Suboxone?
oh, that's to yes, use Suboxone.
Okay.
Yeah, and it's from it was a study in Appalachia where they had a lot of exposure to this from some faculty there. But again, naloxone is safe in pregnancy. Do use buprenorphine naloxone because it's less misusable and there's less impetus for diversion with an naloxone in it. And so if someone's like, "I'm pregnant, I can't have that." Well, actually, yes, you can. And so using buprenorphine on its own is I struggle to think of a situation where the risks would justify any benefit. So there was some thought of like, it might cause more headaches, or again, oh, we shouldn't use it because it can harm the fetus, and that's not consistent with the literature. I've not seen any updates here when I've looked, but again, if somebody has another citation, I'm happy to see it. But again, buprenorphine naloxone is the standard in pregnancy. That's what I've used with my patients when we've continued their treatment during pregnancy, and they've done great.
Um, yeah, feel free to maybe keep the questions coming. Oh, here, let's see. Follow-up comment from Lindsay. Here she says, "Wow, I worked in Tennessee, and all the women would say their mat changed them to only buprenorphine
Mhm.
without the
I think
naloxone
that is a
added."
misconception. Which, and again, it's not only patients that may think that, as we're seeing. So,
Hmm.
but again, obviously, like pure buprenorphine without the naloxone is more misusable, and so it's both for that patient's benefit and for the public health benefit. And again, you can reassure patients and maybe other medical practitioners, like, yeah, actually, this is fine. So. And again, if anybody didn't catch that, you want to email Will, I can get you this study pretty easily. So, um, oh, nice. Yep. Yeah, I've had one of my success stories. I can see them in my mind right now. One of my PAs had somebody who was stable. Both the patient and her boyfriend. They had a successful conception. She referred over to me because I've had obstetric experience, and I kept doing the same thing. And she did great. And then she came. I saw her postpartum. She had a fat, happy baby. And then things kept going well. Both of them stayed in recovery, got pregnant again. Excuse me. And then came back with a very large, fat, happy toddler, and then had another fat, happy baby. And they're all doing great. So yeah, this and again, it will be harmful to deny this necessary treatment to people just because they're pregnant. So yeah, that's awesome. And again, the folks like these have a chance to have a family and have a life, have a good life because of this treatment. So, but that's great. So okay, so let me go back here. Okay, so. All right, so I will go ahead and launch into HIV updates. Again, syndemic is the word. These things do run together. And the poster child for this is the HIV outbreak in rural Indiana, where family physician Dr. Will Cook was doing, minding his own business, running his own little private practice, and there was an explosion of HIV cases, and this was due to injection drug use. And if you remember all the like biopsychosocial factors I was talking about earlier, these were people from literally the wrong side of the tracks. There were those people from that side of town. And in some families, grandparents were showing their grandchildren how to find a vein and inject opioids. And if that is not the bleakest statement, if somebody has a bleaker statement than that, I honestly don't want to hear it because, good Lord, that's depressing. So, and so again, was it the opioids? Was it all the other factors that led to these families being in that situation? I doubt they were doing amazing overall. And again, people not having jobs, not having prospects, not feeling good about themselves and their future, it all goes together. So, but again, if we have people who we know are using drugs and we have the privilege and opportunity to see them for medical care, because a lot of the time they're just not showing up outside of crisis, we can offer them HIV prevention. There is excellent data both for high risk sexual behavior and high risk injection and drug use behavior. And if somebody is capable of pregnancy, Truvada brand name or TDF, FTC, tenofovir disoproxil fumarate is preferred because there's still not adequate data for tenofovir alafenamide in the brand name Descovy working in the vagina that somebody is using. So, and people may have a vagina and not use it for sex. It's important to think of, talk to people about what parts are going where and have that discussion with a good sexual history. But TDF, FTC, or brand name Truvada is usually going to be our go-to. And this is for prevention. Once somebody is in treatment, it's a little different. And then there's now two injectable preventive treatments. Cabotegravir is an integrase inhibitor. The relevant fact there is that the first line maintenance treatment for HIV is an integrase inhibitor. If you have a breakthrough infection on that class, you lose that class for treatment too. So that becomes more complicated. There's still options, but I don't personally use this because of its complexity and the cost. Unless you're working closely with an HIV specialist, I would recommend using the pills. They're safer, less hassle, much more affordable, much more accessible, and the stakes are a bit lower in that there's not a chance of losing integrase inhibitors as a treatment class. And you have to be really careful to diagnose HIV when somebody's already on these again. But if anybody's really interested, happy to talk offline. But I personally use the oral treatments. So, um, and again, just as I was saying, if somebody loses one class or one agent of a class, they usually lose them all. And there used to be some concern for neural tube defects in integrase inhibitors, but that's been shown to not be the case. I'm thinking of another patient who is living with HIV, who I helped optimize her blood sugar control and helped her lose weight. And then she was able to conceive, stayed on Bictegravir, TAF, FTC, or brand name Biktarvy throughout the pregnancy. Again, had a fat, heavy baby doing great. So, and it can be continued as pre-pregnancy, through the pregnancy, post-pregnancy. It's the first line treatment. So, and then this is from an NIH associated site from. And I kept a screenshot. I didn't go back and look at what it is today. So just bear that in mind. Um, you can use this. There's also injectable treatments. Again, that's probably outside the scope of most folks here. But again, if somebody's on this twice every 2 months shot for treatment, that's not as preferred for people who may be pregnant. So again, you talk to your local HIV or infectious disease specialist. They should be aware of this. But again, Bictegravir based treatment, one pill once a day, is going to be your best bet for people who are capable of pregnancy in general. And then this is pretty exciting news. The lenacapavir is a capsid inhibitor, which again has a different mechanism. There's no chance of resistance to other agents, including the first line treatment, if with this, but also it seems to do extremely well. And then I think there's it has a different name for PrEP as it does for treatment, kind of like, semaglutide has 9 different names depending on what you're using it for. It's all silly pharma company stuff. But lenacapavir, since I wrote this a couple of years ago, has now been approved late last year for PrEP, and it does extremely well. And It's an every 6 month shot. An advantage is that you don't have a bottle of pills at home that says, "Hey, I'm taking something that's associated with HIV." Depending on who's coming into your home and maybe poking around in your medicine cabinet, especially in a small town, if there's not as much anonymity as in a larger city like Omaha or like Chicago or something. Having the shot and not having a bottle of, "Hey, I'm at risk for HIV," can be a big psychological benefit for some folks. They can feel safer. Even if they're in a loving relationship, if they're in a not loving relationship, that could be even more important as a way that they can protect themselves without, cluing in somebody who may be harassing or abusing them, which again, I wish that never happened, but we know it does. And Again, this is something that has data in pregnancy as well. So this was an update from IIS 2025, so pretty, I think from late last year. But Injectable cabotegravir, which again I wouldn't recommend as much unless you really dive into it and are skilled in that, and lenacapavir, which also needs a fair amount of infrastructure, but again, they're both safe and effective for people who are pregnant or may be pregnant. There's good data, and again, as the speaker here pointed out, this professor, pregnant and lactating folks are disproportionately vulnerable to HIV. A lot of studies have excluded them because they're like, "Oh, well, we don't want that complexity." Some of these studies, which were done in part in Africa, as is often the case, so that's a whole nother discussion about who's having the studies done on them to benefit other people. But again, there is data that pregnancy is not a reason to avoid this and that they're safe and effective. So again, talk to your local HIV nerd and or infectious disease professor, contact consultant, and if you don't have one of those, reach out to Will, and I will help if I can. I also have connections with some HIV expert faculty at Nebraska Medicine who can and will do trainings if people want to get something set up. And Again, it's a very collaborative group of mission-driven people. Okay, and then just wrapping things up. This I did capitalize. Vaccination is still a good idea. And When I see statements that we don't need to immunize babies because hepatitis B is sexually transmitted, and so we don't need to worry about that. I keep going back to, do you all know where babies come from? Like, seriously, I'm not sure. And having taken care of immigrants who have chronic Hep B from birth, these are teenagers getting liver biopsies and waiting until they, and looking for reasons to treat and then trying to prevent cirrhosis. And congratulations, you have this thing that you're living with for the rest of your life. Boy, would it be nice not to have to do that. We should screen in every pregnancy. We should vaccinate. A lot of times the prenatal panel will look for a Hep B antigen, but it won't confirm if they're immune. I try to think about this with my universal HIV and Hep C screening to also check Hep A and B. Hep B especially for pregnancy, Hep A for sex, but I mean, honestly, check everybody. A lot of my immigrants are immune to Hep A from natural infection, but not immune to Hep B, and you will catch some people who have chronic Hep B as well. It's asymptomatic. Thinking about treatment, HIV, find it, treat it immediately. Hep C, find it, kill it immediately. Hep B, there's an immune tolerant chronic phase, and once you start on treatment, you need to stay on it, so it's more nuanced. Again, talk to your local infectious disease friend, and if you have trouble connecting with somebody, reach out, and we'll get you hooked up with the right people. And then both vaccination and Hep B immune globulin should be done at delivery. Again, if you're going to treat tenofovir with or without HIV being present is the way to go. It's superior to the other options in my opinion and the data. So. Okay, and then Hep C again. This is destroy on site, and you should be screening for Hep C in pregnancy. Again, I didn't update this. I don't think the syringe exchange program is coming back this year, but if it does come up and you happen to notice that, please encourage your representative to move that forward. They are a slam dunk. And Again, treatment is prevention is the idea here. uh, can't transmit Hep C if we already nuked it. So, and most of the time, if you catch it during pregnancy, you can wait until after pregnancy to treat it. But again, this is something that is very doable. If you have somebody and you're not sure, please get in touch with Will. I would love to help you pursue a goal of zero hepatitis C cases in Nebraska. So, uh, okay. Had to wrap it up the meme. Appreciate everybody giving their time and attention this morning. If anyone has any questions for the last couple of minutes, I will stop talking and I'm happy to take those.
Awesome. Thanks, Alex. Yeah, we've got a couple minutes here if anyone wants to drop a question in. While we're waiting on that, I did put in a link to the evaluation survey to get your certificate for today. And just a reminder, our new system, once you complete that survey, you just have to wait up to no more than 2 business days, and I'll get the certificate emailed out to you. Slightly different process than before, but the certificates will be a little bit better going forward. Okay, so we can kind of pause for a minute. Questions, comments, feel free to unmute and speak up.
This is the Whirlpool Galaxy, which is one of my favorite deep sky objects, and I have actually seen it in visible light through a telescope. It doesn't look quite this cool. It doesn't have the X-rays and other stuff when you just look at it with your eyeball. Yeah, so I just threw that in there because I think astronomy is cool.
Awesome. Awesome. Well, I'm not seeing any questions or comments, so we can go ahead and end it there. Thanks, Alex, and have a good Friday, everybody.